Cases of the flu are skyrocketing around the country. Perhaps it's at your own home. Areas like New York City being hit particularly hard, though. Preliminary hospital data shows that in the week ending on December 20th, more New Yorkers went to the emergency rooms with flu-like symptoms than during any other week in the past decade. Experts say the spike is being driven by a new strain of the flu that has mutated in ways that help it evade the body's immune defenses and makes it not an exact match for the virus included in this season's flu vaccine. Joining me with more, MS Now medical analyst Dr. Vin Gupta. Let's just go straight to the question here, Dr. Gupta. Is it worth folks going and getting the flu shot if the vaccine, the one that is currently on the market, is not a perfect match for this new variant?
Good morning, happy holidays. Short answer is yes. We do have data from overseas countries like the United Kingdom showing that it still does keep somebody that gets vaccinated away from somebody like me, a pulmonologist. So it is still effective at its purpose, which is not to prevent infection, but to prevent severe pneumonia. And it still does that. Are vaccines, flu vaccines in any given year, perfect at keeping somebody out of the hospital? No, and that's what we're seeing, that it's imperfect at that, but it's still very effective. So it's important to get that. And I just also mentioned when it comes to flu, anybody, especially high-risk populations, if you have a kiddo under 2, Vaughn, if you're over 65, if you have underlying condition like asthma, and you feel like you have flu-like symptoms, especially with holiday gatherings, think about getting tested. There's online tests, just like during COVID, peak COVID days, where you can get a COVID flu test. And that's important because early treatment with Tamiflu can keep you out of the hospital.
And Dr. Gupta, tariffs will be a factor. They're a factor in a lot of things, but they're also a factor in the rising costs of medication that folks are getting. There are some states, though, like California, that we are learning are taking steps to counteract this. Can you tell us more about what California and others at the state level are looking to do?
But it's really interesting. There's an effort underway, Governor Newsom, that's been in place now for the last few years through CalRx, where they're actually partnering with pharmaceutical companies, leveraging the incredible purchasing power of the nation's largest state to, in effect, help manufacture, produce their own medications. Like naloxone, they just announced. Naloxone's going to come to market in 2026 in California. Their own CalRx branded naloxone for $19. That's over 50% off the market price at $45. They did something similar with insulin and a biosimilar for insulin glargine, which is long-acting insulin. Now you can get a 5-pack a month supply for $55. If you're underinsured or uninsured, it can be an 80 to 90% discount off the sticker price. So California is using its market power to partner directly with pharmaceutical companies, especially at a time in which there's a lot of headwinds at the federal level when it comes to pharmaceutical supply.
And finally, we want to ask you about the latest Trump executive order on affirmative action, on marijuana. There is the question here ultimately about what the impacts will be on the hemp industry. Can you give us some insight into what folks should be expecting?
Yeah, this has been long awaited, and I'd say, Vaughn, this is one of the few areas in healthcare where there's a lot of bipartisan energy that it is believed that marijuana largely should have been rescheduled from the Schedule I drug, highly constrained along the lines of, say, Medicaid or drugs like heroin. That's how we currently regulate it. Can't research it, can't use federal dollars to research its medicinal properties. What could it actually be good for, or where there are potentially medical risks in how we utilize marijuana? Now we're saying, and the Trump administration is really putting forward, let's reschedule it to a Schedule III drug, which would allow federal dollars to be used for medical research, which I think is critical. It's highly under-researched when we really think about NIH dollars being put to use to understand what are the positive effects of marijuana for, say, chronic pain. We know that there's a lot of positive effects, but let's get high quality research. That's one impact here. And two, this is just going to align federal policy more closely to state policy. States are already doing this, already providing recreational marijuana to its citizens. Federal policy should mimic state policy in this case, and that's what this is going to get us closer to.